Evaluation and treatment of congenital scoliosis. The evaluation of congenital scoliosis includes clinical evaluation, radiological evaluation of deformity, and radiological evaluation of associated conditions. The clinical evaluation, apart from a routine spinal evaluation, evaluates the skin of the back to look for any hair patches, lipomas, dimples, or scars which may indicate an underlying neural abnormality. We also look for any evidence of neurologic involvement like clubfoot, calf atrophy, absent reflexes, and atrophy of one lower limb compared to the other side. We also look for any syndromic associations like Vater and Bacterial syndrome. The radiological evaluation of deformity consists of plain radiograph, which include the whole spine posterior-anterior view and the lateral view. A posterior-anterior view decreases the radiation exposure to the gonads and the breast tissue compared to an anterior-posterior view and is thus preferred. In the radiographs, we look for the type and number of anomalies, the growth potential of the spine. We look for any widening of the pedicles or midline bony defects, which may indicate an underlying cord anomaly, and we estimate the curve magnitude by Cobb method. A non-contrast CT of the whole spine with a 3D reconstruction may help with a better characterization of the bony anomalies. Radiological evaluation of associated conditions includes an MRI of the whole spine with craniovertebral junction, which may help us look for neuroaxial abnormalities like tethered cord syndrome, split cord malformation, syringomyelia, or intradural lipoma. Genitourinary abnormalities are ruled out by an ultrasound KUB. Cardiac defects are ruled out by echocardiogram, and a pulmonary function test can help us assess the presence and the degree of restrictive lung disease. The treatment may be non-operative or operative. Non-operative treatment has limited role in congenital scoliosis. It consists of observation for non-progressive curves. During observation, we have to be very careful in the periods of rapid growth, which are 0 to 5 years and 10 to 15 years, or the pubertal growth spurt. In observation, we have to perform radiographs every 6 months or twice a year. Bracing is again not very effective and is used to control secondary curves when the primary congenital curve is being treated conservatively. If bracing is used, again radiographs are obtained every 6 months. Before we go into the operative treatment of congenital scoliosis, we have to understand how the deformity develops in failure of formation and failure of segmentation. So here we have a fully segmented hemivertebra, which is a failure of formation. Here, compared to the concave side, there is overgrowth on the convex side due to the growth potential of these end plates in the hemivertebra. The growth potential of the concave side is near normal. Whereas in a failure of segmentation, there is a decreased growth potential on the side of the bar, whereas the growth potential of the other side is normal. So, in both cases, there is an imbalance of growth. However, in failure of formation, there is overgrowth, and in failure of segmentation, there is decreased growth of the concave side. The operative treatment of congenital scoliosis can be divided into procedures which aim at prevention of future deformity, gradual correction of deformity, and acute correction of deformity. In prevention of future deformity, we have in situ fusion, in which the curve is fused as it is without any attempt at correction. These are suitable for smaller curves. The procedure can be posterior fusion only or a combined anterior and posterior fusion. This may be done with or without instrumentation. In gradual correction of deformity, we have convex hemiepiphysiodesis with a hemiarthrodesis. We also have guided growth procedures. The common among them are growing rods and Vector or the vertical expandable prosthetic titanium rib. In acute correction of deformity, we have instrumentation and fusion, which can be posterior or anterior and posterior, hemivertebra excision, and corrective osteotomy. Coming to posterior spinal fusion. This can be done in situ or with acute correction of deformity. We must know about crankshaft phenomenon. So, what is this? If posterior fusion is done in a patient with a significant anterior growth potential, the growth of the anterior part will cause an increased rotational deformity and bending of the fusion mass, which may worsen the deformity in case of a posterior spinal fusion. Posterior spinal fusion may be done without instrumentation or with instrumentation. Without instrumentation, there is lesser correction of deformity, more chances of pseudoarthrosis or failure of fusion, a requirement of postoperative cast or brace. However, there are less chances of neurological injury without instrumentation. With instrumentation, there is more correction of deformity, less chances of pseudoarthrosis, less requirement of postoperative cast or brace. However, the chances of neurological injury are higher. To avoid this, we use neuromonitoring, that is SSAP and MEPs. All cases of congenital scoliosis, when we are operating and trying to achieve correction with or without instrumentation, we prefer to use neuromonitoring. Coming to combined posterior and anterior fusion. When an anterior procedure is added to the posterior procedure, it aims to increase the flexibility of the scoliosis by doing a discectomy. Also, we remove the anterior physis to prevent crankshaft phenomenon, which may be common with a posterior only procedure. The anterior procedure involves removal of the disc, cartilage end plates and bony end plates, and bone graft in the form of bone chips is placed into the disc space for fusion. The posterior procedure follows the anterior procedure and final correction with or without instrumentation is performed. Convex hemiepiphysiodesis. The principle here is similar to long bones. The physis on the convex side is fused. So what does it do? It slows the convex side growth while the concave side continues to grow. It is appropriate for patients with significant growth potential of the concave side. So, since the correction depends on the growth of the concave side, there must be a significant growth potential remaining on the concave side for this procedure to work. So, this is not very useful in failure of segmentation, as we already saw that in failure of segmentation, the growth potential of the concave side is decreased. Also, the patient should be young so that there is significant growth potential of the concave side. Less than 7 vertebrae should be involved. The curve should be less than 50 degree and there should not be any pathologic congenital kyphosis or lordosis present. Epiphysiodesis of the entire curve should be performed and not merely the apical segment. A rigid spinal immobilization should follow this procedure until the fusion is solid, which is usually 6 months. Hemivertebra excision. Here we remove the cause and produce immediate correction of the deformity in a case of convex hemivertebra. So, the resection of the hemivertebra is performed. Both the anterior and posterior part of the hemivertebra is removed, followed by a wedge closure of the defect with instrumentation. The best suitable candidates for this procedure are angular curves with a hemivertebra at apex and patients with pelvic obliquity or fixed lateral translation of thorax which cannot be corrected by other means. Lumbar and lumbosacral hemivertebra are the safest to remove and thoracic hemivertebra have more risks. So in the thoracic area, we only go for this procedure if there is a need for these procedures and other procedures are not likely to succeed. It is best done in patients younger than 5 years before structural changes develop in the adjacent vertebra. Hemivertebra excision has a higher risk than the previous procedure, that is convex epiphysiodesis, but obtains a better correction. Coming to guided growth procedures. These are non-fusion surgeries. There is a concern with early fusion surgeries that they may lead to thoracic insufficiency syndrome due to inadequate development of the lung function. The most common surgeries are growing rods and Vector. In growing rods, we take anchors in the proximal and distal part of the curve, and these are connected by rods, and we distract the concave side more than the convex side. This differential distractions correct the growth imbalance. Though both single and dual rods can be used, a better correction with dual rods have been noticed. Growing rods may be conventional growing rods or magnetic growing rods. In conventional growing rods, these require surgical distractions every 6 months. So the patient has to undergo multiple surgery. Whereas in magnetic growing rods or magic rods, these distractions can be done without surgery from outside with a magnet. However, the magnetic growing rods are more costly. Once the patient reaches maturity, a final fusion is performed, which may be in situ if the deformity remaining is acceptable, or with a final correction if the deformity remaining is unacceptable. One concern is posterior distraction in spine can increase the kyphosis, so this procedure is not very suitable in patients with a concomitant congenital kyphosis. Coming to Vector, this is also known as vertical expandable prosthetic titanium rib. In this, anchors are taken on the concave side on the ribs in the proximal part. In the distal part, the anchors can be in the spine, in the ribs, or in the pelvis. Now, when we have fused rib, this procedure is more appropriate. So, at the location of the fusion at the apex on the concave side, we do a expansion thoracostomy, which is a open wedge thoracostomy on the concave side at the apex of the deformity, where the concave hemithorax is most tightly constricted by the rib fusion. Now, once this thoracostomy is performed, these anchors are connected by the Vector device, which has central sleeves which slide over each other, and the spine is gradually distracted to achieve spinal length and improve the pulmonary function. Coming to osteotomies, these are more appropriate for complex curves with multiple fusions and previously fused curves with significant truncal imbalance. Multiple anterior and posterior osteotomies may be required, and the most commonly used osteotomies are pontiosteotomy, pedicle subtraction osteotomy, and vertebral column resection. So friends, this was a presentation on the evaluation and treatment of congenital scoliosis. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also, comment in the comment section regarding the topics you will like to be covered in the future videos. Thank you.